Okay, everybody. So it's just turned the hour, so I think we might get started, and then obviously some more people might join over the next couple of minutes. Zainab's facilitating the session. My name's Beth, and I'm an F1 doctor at Royal Shrewsbury Hospital, and I'm going to be running the session. The session is being recorded, so if anybody's got any kind of concerns about that, please let us know. We can answer any questions, but it's just so more people can see the session after it's finished, or like you can refer back to it for revision purposes and things like that. I am sharing the slides now. Can somebody please just let me know in the chat if you're able to see the slides? Okay, perfect. Thank you. So during the session today, we're going to do some practice questions and things like that. When we do the questions, how we'll do it is I'll just pop a message or ask Zainab to put a message in the group in the chat, and basically when you've done the question, we'll just ask you to like react or like thumbs up or something like that to the message, just so we can kind of keep track of where everyone's up to and if people need more time. Feel free to ask questions at any point during the session. That's absolutely fine, but we'll also do like questions and things like that at the end. So yeah, okay. This is another one of our Road to the PSA sessions. This one is all focused on paediatric prescribing. Like I said, so my name is Beth, and I'm a Manchester graduate. I graduated last year. I'm currently in F1, working at Royal Shrewsbury Hospital in the West Midlands. In terms of what we're going to cover today, so a little bit about kind of using the BNF in paediatric prescribing and just making you aware of some of the basics of things like that. And then we're going to be going over some of the more commonly common topics when it comes to paediatric prescribing. So that's dosing by weight and body surface area, pediatric fluid prescribing, because it does differ quite a lot than adult fluid prescribing, and I think that's a question that comes up, I would say, most out of any of the pediatric questions, and then also just some of the common pediatric prescriptions and things to keep in mind when coming into contact with your pediatric questions in the PSA. So just to start off, just a little bit of the basics about pediatric prescribing. So hopefully all of you are kind of used to using the BNF by now, and generally if you go into a drug, I've just got paracetamol up on the screenshot, you will be somewhat familiar with that. It looks like this, and you can see at the top you've got the green little banner with the BNF down the side of the screen. That is your adult BNF, and so it's important to make sure that with any questions where you're doing anything for children, that you first off, before you do anything, is that you make sure that you leave the adult BNF and you go to the pediatric BNF instead. So as you can see here, so for paracetamol on the adult BNF, it does actually have some information about paracetamol prescriptions for children. So you can see here we've got child from 3 to 5 months, and we've got different intervals and different doses upwards from there for pain and pyrexia with discomfort. However, if we go to the BNF for children, so all you do by doing that little kind of green icon that says BNF, you click on that and you change it to BNFC, which is BNF Children's, and you should have a pink banner at the top whenever you're doing your pediatrics questions. If you go to the same drug, so we go to paracetamol again, you can actually see there is more information and more age ranges and things like that available on the children's BNF, which just goes to show why it is quite important. Even though the adult BNF does have some pediatric information, you should always go to the BNF for children when you're doing your pediatrics question. It takes no effort to change over, but you're basically going to make sure that you're getting more accurate questions and things like that. Just as well, just another thing just to keep in mind with your pediatric prescribing, something that we don't necessarily always think about when it comes to adults, is thinking a little bit more about who our patients are at their different age and their likely developmental milestones. You can see here that we're talking about paracetamol by mouth, but I don't know about you, but a lot of kind of my interaction with babies and things like that is that a baby or a neonate or 1 to 2 month old child would really struggle to have like paracetamol tablets. So just to keep in mind when you're doing your pediatrics prescribing, just to keep in the back of your mind, particularly with very young children, about the preparations that you're putting in the BNF. So I think normally when prescribing paracetamol, I would always just do your kind of normal 500 milligram tablets. But with children, you maybe need to think a little bit more closely about, do I need to do like a liquid or like a oral solution or something like that instead. So just to keep that in the mind. So yeah, make sure you're using the correct section of the BNF, so your children's BNF, and just make sure that you're taking into account kind of with particularly with young children or babies about whether they'd actually be able to swallow a tablet, and keeping that in mind when you're prescribing. So we're just going to have a couple of little practice questions to think about using the BNF for children, just to get you used to actually making sure that you're in the right section, and that you're selecting the right drugs and the right doses for the right age patient. And this slide here is just to demonstrate the fact that unlike with your adult BNF, although sometimes you might have drugs which maybe have kind of elderly doses, that obviously isn't quite as common, whereas with almost every medication on the children's BNF, your doses will be split up into by age. So also just make sure that you're keeping in mind when you are doing pediatric prescribing, that essentially you're looking at the right dose for the right age child, and like silly things like make sure that you're being careful that you're not getting mixed up with like months and years and things like that when you're selecting the right age. I know that sounds like a really simple mistake to make, but when you're stressed in a very time pressured exam, it's so easy to make those little mistakes. So just keep that in the back of your mind as well. So like I said, so we're going to do a couple of little practice questions just to make sure that you're all comfortable using the pediatric BNF. So we're going to speak about paracetamol because we've already kind of had that up earlier in the presentation. So question 1, so what dose of oral paracetamol should be given to a 5-week-old baby to manage their fever? So I'll give you all a couple of minutes. If Zainab, if we can pop a message in the chat, and if people can just react to that message when you've done the question and you to go to the answer, and when a decent number of people have done it, we can move on.
I need to do this PSA lecture.
Just seen there's a message in the group, I can say group chat, sorry, in the chat, about access to recording. So yeah, you'll be able to get access to the recording once you've filled in the feedback forms and things like that at the end of the session. So if we can all just make sure when you've done the question, if you can just react to the message in the group, just so we know when's best to move on. So I can see roughly half of you have now thumbs up the message. So we'll go to the answer, and if anyone has any questions, that's absolutely fine. So hopefully all of you have gone to the Children's BNF, and you should get this little screenshot up here. So you go to paracetamol, scroll down to the correct indication, and you can see, so a 6-week-old baby, they would fall within their age range 1 to 2 months. And so your correct answer for this question would be 60 milligrams 8 hourly, or TDS as required. It would also be completely acceptable to do 30 milligrams 8 hourly, as that also would be kind of within that range that they've given. Okay, so question 2. So patient A is a 6-year-old with a respiratory tract infection who requires a course of oral clarithromycin. She weighs 18 kilograms. What dose of clarithromycin is appropriate for this patient? So same thing again, so just have a little look on the BNF, get your correct answer, and then we can talk through it when everybody has done. So same as last time, Zainab, if we can get a message in the chat about that, and if people can react to it once they've done the question. Okay, so again, I can see just under half of you now have reacted to the message. So we'll go to the answer just because we do have quite a lot to cover in this session, if that's okay. So same thing again. So hopefully on your children's BNF, you should go to clarithromycin, find the correct indication, which was respiratory tract infection. And then same thing again. So you just go down to the correct dose for the child's age or the child's weight, or in this case, you're actually considering both of those things. So because she weighed 18 kilograms, she fell into the category for the slightly larger dose. So it was 125 milligrams twice daily. And question 3, so this is the final one of this set of questions before we'll move on to some other bits and pieces. So patient B is a 10-year-old patient that requires treatment with oral cyclizine for nausea and vomiting. What is an appropriate dose of cyclizine for this patient? So again, we'll pop a message in the chat, and then when you've got your answers, if we can just react to that. Okay, so again, I can see quite a few of you have now reacted to the message. We'll go on to the answer for this question. So as you can see, so it's 10-year-old patients, so they fit in the age range of 6 to 11 years. So for this patient, it'd be 25 milligrams up to 3 times a day. And yeah, that's about it for this one. If anybody has any questions about that, just make sure you pop them in the chat and we can get to them. But it doesn't seem there is anything at the moment, so we'll just move on. So this is going to be dosing by weight or body surface area. This is something that comes up quite a lot in paediatrics, just because the patients are quite a bit smaller, and you do have to take into account their weight more often to make sure they're not given like too much medication or anything like that. So in terms of dosing by weight, it's actually quite a simple formula that you need to do. But essentially your dose is your weight in kilograms, or kind of another unit if they specify, but generally it is kilograms, and then your dose per kilogram in whatever unit that might be. Most often we see kind of milligrams, but it might be so many grams per kilogram or micrograms per kilogram. Especially in neonates, you probably see micrograms more often. Just to make you aware as well, unless it's specified somewhere else in the question, this goes for both adult patients and pediatric patients, that unless it says anywhere else, you use the patient's actual weight. Sometimes you might have questions where it mentions the patient's ideal weight or pre-pregnancy weight or dry weight. That comes up kind of very rarely. I think there's maybe one question on my PSA where ideal weight was mentioned, and for the others I never saw any of those questions. But it's just to make you aware that they can use a different weight, but generally it will be the patient's actual weight, and so you should always presume it is that. So we'll just work through a bit of an example question together, just to make sure that you're all comfortable with the format and kind of how we would do this question. So patient A weighs 13 kilograms. They require a 25 milligram per kilogram dose of drug B. What is the correct dose of drug B for this patient? So we would just, for this question, we would times 13 by 25 because it's 25 milligrams per kilogram. And they weigh 13 kilograms. That comes to 325 milligrams, and that would be the correct dose for that patient. So yeah, so we'll go on to a couple of practice questions now for these, unless anybody has any questions. I've just seen a message in the chat about would you give rectally because she's vomiting. I'm presuming this is about the cyclizine question. Yeah, if somebody's vomiting, you can absolutely give it rectally. I think rectally is something that we would give much less frequently in children, because that could be quite distressing. To give a child kind of a rectal medication, I think it'd be more often that we'd use kind of an IV or an IM dose, which you can give for cyclizine as well. But yeah, use a non-oral route in a vomiting patient, that's kind of definitely something to consider. Yeah. So for question 1, for this set of questions, so we've got patient B is a 9-year-old who requires treatment with vancomycin for cellulitis. They weigh 25 kilograms. What is the appropriate dose of vancomycin for this patient? So we'll pop a message in the group chat, I keep on saying group chat, sorry, in the chat, and just please react to it when you've done the question. Okie dokes. So you can see quite a few people have reacted to the message. So we'll go through the answer for this question. So hopefully first off you went to vancomycin and found the correct indication, and then we're able to identify that this patient would fall into this first category for their dose for an IV infusion of vancomycin. So they would require 10 to 15 milligrams per kilogram every 6 hours. We know that kind of dosing of vancomycin and gentamicin and things like that, it can be a little bit complicated, but this is just for our initial starting off dose. So in this case, I personally started with the lower of the 2 doses. If you wanted to do kind of 10 or 15 milligrams, either of those is absolutely fine for your calculation, providing that it's either one of them or within that range that they've given. But I did 10, so I did 10 times 25, which gives us 250 milligrams QDS or 6 hourly for this patient for their vancomycin dose. Like I've put here, just like a little bit below, if you did it 15 milligrams per kilogram, that's absolutely fine. And that would give you a dose of 375 milligrams. Equally, if you'd maybe worked out both of these and you'd come up with a dose somewhere in the middle, that again is absolutely fine. Essentially, providing that you're within that range, the answer would be correct. The only time when maybe you might get less marks for a less ideal answer is if your question, if your the dose that you pick would be quite difficult to formulate. So for example, if you go on the BNF and you can go on kind of the formulary of medications and you can look in what doses that it comes. So if comes in preparations of 250 milligrams or 100 milligrams or something like that, it will be much more easy to make a 250 milligram dose or a 300 milligram dose, for example, than it would be if you say picked a random dose of about 325 milligrams. So if you're kind of given a range and you're unsure of whereabouts in that range to pick your dose, thinking about checking what kind of preparations it comes in and how easy that would be to make up the dose that you've prescribed essentially is something to consider, because this is an IV medication. You don't have to think about that quite as much. It's more commonly with tablets that could be an issue. So yeah, so we'll move on to question 2. So patient B is a 13-year-old who's been admitted to hospital following a life-threatening asthma attack. They require treatment with oral prednisolone. They've not previously received any steroids. They weigh 32 kilograms. So essentially, I've not actually put the question here, so I apologise about that. But the question is, what's an appropriate dose of prednisolone for this patient? So same again, if we just let us know when you've done this question. Okie dokes. And go through that question. So again, so hopefully you were able to go to prednisolone and you can identify, because this patient is 13 years old, they fall within the 12 to 17-year-old dosing. And so for this patient, oh, sorry. I think I've written down the wrong, oh, okay, sorry. I've not. So basically, so because they fall within the 12 to 17-year-old category, their dose is actually 40 milligrams once daily, or you could do 50 milligrams once daily. That would also be absolutely fine. But I think I was just trying to catch you out, just because obviously I think we might be tempted, because we're doing like milligrams per kilograms dosing. It's quite easy to see this like section where it says 1 to 2 milligrams per kilogram. And yeah, work it out. But yeah, so 40 milligrams for this patient. Oh, yeah, okay. So for question 3, so we've got patient C is an 8-week-old who requires treatment with, I can't pronounce that, but it's more commonly known as Tamiflu. For the flu, they weigh 4.5 kilograms. What's an appropriate dose of Tamiflu for this patient? And again, if anyone has any questions about any of the questions that we've done, please just pop them in the chat. We can just get back to them whenever. Okay, we'll have a little look at this next question. Also, if anyone feels like we're going too fast at any point with any of these questions, please do just feed that back, as it can be a bit tricky to guide pacing when I can't actually see you all. But yeah, so question 3. So hopefully you're all able to find the drug, even though it's felt a bit weird, on the BNF, and able to identify that because this patient was 8 weeks old, their dosing is that kind of third bracket down, so 1 to 11 months. So they required a dose of 3 milligrams per kilogram twice daily. For this patient, so that'd be 3 times 4.5, which is 13.5 milligrams. You can also see that on that dosing instruction, it says maximum of 30 milligrams per dose, 13.5 milligrams as well within that range, so that's absolutely fine. And also just to make sure that we're prescribing it at the right frequency, so twice per day or BD. So yeah, those are those questions. If anyone's got any questions about dosing by weight, please do just let us know. But if not, we'll kind of move on to the next section, which is dosing by body surface area. We've only got a couple of questions about dosing by body surface area for children, because it is really not something that comes up a lot at all. I think at most you might have one question on this on the entirety of the BNF, or you might not actually have one of the BNF, of the PSA, or you might not have one at all. But essentially, most of the time when we think about dosing by body surface area, we use what we call the Monstella formula. You would never be expected to remember this. They'd give you it in the question if you were expected to use it. But it's this kind of big calculation we've got here. But actually, when it comes to children, we don't use this calculation at all, just because kind of pediatric but body surface area is a little bit different. So what you actually can do when it comes to body surface area questions for pediatrics is if you go to your children's BNF and you search body surface area, comes up with a little link here to a page which is body surface area in children. And on that page, as soon as you click onto it, you have this page where it comes up with essentially a bunch of body weight and what their surface area would be for that child. This is the table for body weight under 40 kilograms, but they also have one for children that weigh a little bit heavier, so for over 40 kilograms as well. So you can find that quite nice and easily, essentially. So essentially, we'll go through this first question together just so that everyone feels comfortable. When it comes to body surface area questions as well, just to mention, they're such uncommon questions because the drugs that actually require dosing by body surface area are incredibly uncommon. Like, I've never prescribed anything by somebody's body surface area. I think generally the medications that use surface area are chemotherapy agents. They're quite specialist drugs that most of us won't prescribe for a very, very long time, if at all. So some of the drugs in this question, these questions might be quite unfamiliar, but it's just about getting used to like what we would do if that question came up for whatever reason. So we'll do this one together. So question 1, so patient A requires treatment with glycerol phenyl butyrate for their urea cycle disorder. They are 9 years old and weigh 25 kilograms. What's an appropriate initial dosing grams? So for this patient, we have gone to our BNF, we've searched body surface area, we've clicked on that link, which is the first one that comes up, and we get to this chart. We know they've got a body weight of 25 kilograms, and so this chart tells us that they have a body surface area of 0.92 meters squared. We then go to the drug. We can then find the body surface area of up to 1.3 meters squared. And then we can see for children within that kind of age bracket of 2 to 17 years. And so for them, they would require 9.4 grams per meter squares in daily divided doses. So I would then do 9.4 times 0.92, which gives 8.648 grams daily. And then because it says divided doses, but it doesn't actually specify how many doses, generally I would either do that in kind of 2, 3, or 4 doses per day. If any of them kind of divide into a particularly nice kind of number, then maybe select that one. I noticed that in the kind of urea cycle disorders, just underneath that it says by mouth or by gastrostomy tube or by nasogastric tube. So I for me personally prescribing this, I would go for 3 times a day, 2.88 grams, because I think, well, then they can have it with meals. That's just like something that I personally would do, about thinking about what's easiest for the patient, and also doing things like 4 times a day. You're just asking a child to take a lot of medication quite frequently, which isn't nice. So less often is a little bit nicer, I think. But yeah. So we'll go to question 2 now, and if you will just do this in your own time and let us know when you've done the question. But that's patient B is a 7-year-old with chronic kidney disease. They are not on any form of dialysis. They require treatment with sevelamer for chronic hyperphosphatemia. They weigh 19 kilograms. What is a dose for this patient? So yeah, just let us know when you've got the answer for this one. Yeah, I've just seen the message in the group chat. Yeah, that's completely valid. I should have rounded that to the nearest 0.5 grams. So it was ended in, I think it was 8.88. So yeah, I'd round it up to the nearest gram for that patient. And just make sure that we've all reacted to the message if you got your answer for this question. I do appreciate these ones are a little bit tricky, so it might take a bit more time. Okie dokes. So we'll have a little look at the answer for this one. So again, hopefully you were able to find the section on the BNF. And if we go to a weight of 19 kilograms, that gives us a body surface area of 0.77 meters squared. If we have a little look on the dosage of this, body surface area for a kind of 6 to 17-year-old with a surface area of 0.775 to 1.1 meters squared. So we fall within this dose for the first bracket. And that actually gives us a dose of initially 2.4 grams daily in 3 divided doses. So we can work that out as 800 milligrams TDS, and make sure that you convert to milligrams, so we don't do 0.8 grams, just because that can get a bit confusing for kind of nurses to interpret the dose and things. So you will be marked on if you put that. But yeah, so hopefully that answer makes sense. And this also just goes to show that sometimes that you do have to use things like by weight or by surface area, but you don't actually have to do calculation at all, which is quite nice. So yeah, so again, same as always, let us know if there's oh, I've just seen the message, we can probably go a bit faster. That's absolutely fine. I was thinking that, but I don't like rushing people. We'll go a bit faster. So we're going to do pediatric fluid prescribing and move on to this because this is quite different in adults. Although it is a little bit different, our actual fluid options and things like that are the exact same as in adults. So we've got our kind of normal saline, which hopefully that you should all be familiar with. We then have things like potassium that we can add as an additive. Remember, you can't just prescribe 0.3% potassium. That's not a fluid that comes. It's something that you have to add to either glucose or to saline. Most often that would be to saline. You've also got other fluids like Hartmann's, and when you're on the PSA website, you can actually see there's a whole host of random fluid preparations and things like that. I think I spoke about in the last session I did that the most commonly prescribed fluid at the hospital I work at is one I'd actually never heard of before when I was at Manchester, called Maintalite. So just to be aware that although these are most commonly prescribed fluids, there's a whole host of fluid options, which I think is quite good just to have a little flick through on the PSA platform before you actually go into the PSA. As sometimes you might want kind of, you might want sodium chloride, but you might want a bit of glucose as well, or a bit of potassium as well, or something like that. And so it's good to be aware that you can prescribe different things to meet the requirements of whatever patient it is that you're prescribing for. But yeah, these are our most common ones. Just to kind of highlight as well, just we're particularly quite careful around sodium in children. So generally I would just use saline, as you don't want to kind of cause hyponatremia and things like that. But yeah, so just to run you through the 3 different types of fluid prescribing that we do in peds, exact same as adults, but it's just the doses and things like that that we do that are different. So resuscitation fluids in pediatrics, so we would always use normal saline, and we would use normal 0.9% saline, and we do 10 mils per kilogram, and you would give it in 10 minutes or less effectively, but 10 minutes is what you would prescribe it as. Just to make you all aware, not so much for the PSA, but just for clinical practice, if you're giving somebody resuscitation fluids and their blood pressure doesn't improve or continues to drop with one, but certainly with 2 doses as an F1, you definitely need to escalate that really urgently. So yeah, just to reiterate that. So then we've got our maintenance fluids, and so in pediatrics we use something called the Holiday Seagar formula that I'm aware of off the top of my head. I don't think you are given this in the PSA, so this will be something that you'd have to remember yourself, although you can find it on the BNF. It's in a section about fluid prescribing, but it's a little bit more difficult to find, and the formula itself is actually quite easy to remember. So I would say just make a flashcard and try and remember it before you do the PSA, because you'll be quite grateful for it. But essentially it's this formula. So for your first 10 kilograms of weight, it's 100 mil per kilogram per day. Then for the next 10, it's 50 mil per kilogram per day. And then above that, it's an extra 20 mil per kilogram per day. And yeah, just to make a little note, actually, with your resuscitation fluids, although it is 10 mil per kilogram in pediatrics, when it comes to teenagers, sometimes you might have kind of teenagers that weigh over 50 kilograms quite, commonly, particularly as you get older teenagers that are closer to adult weight. Just keep in the back of your mind that adult resuscitation fluids, it's 500 mils. So I wouldn't, for a child, be prescribing more than 500 mils for their resuscitation fluids just based off of their weight. So just that to keep in mind. But yeah, sorry about that. And your replacement fluids. So this is the one where it gets a little bit more matty. But essentially, for your replacement fluids, you need to know everything from that previous slide. So this is your maintenance fluids, and then you essentially need to work out how much fluid that you need to replace on top of that. And this is over a 24-hour period. So essentially, your fluid that you need to prescribe in a 24-hour period for a patient who is in a fluid deficit or is dehydrated is their maintenance fluid plus their fluid deficit. And you work out your fluid deficit by this calculation here. And again, to the best of my knowledge, this isn't something you'd be given in the PSA, so it's worth making like a flashcard or however you remember your equations for this. So that basically is your percentage dehydration times your weight times 10. In the majority of questions that I've seen, and generally in clinical practice, your percentage dehydration isn't something that we typically work out very often. I know I've worked on gastro, so we have a lot of dehydrated patients and people with like ulcerative colitis and Crohn's and things like that, or just people with awful gastroenteritis. Similarly, you might have people with DKA, they can be very dehydrated as well. The consultant generally would estimate how percentage dehydrated they think they are and would tell us that and work it out. And I think off the top of my head in the PSA, we were told what percentage dehydration patients were. But just to make you aware that there is actually a calculation where you can figure out as well. So that would be the patient's well weight, take away their current weight. So essentially what's their change in weight. Now they've been unwell over their well weight, and then you're timesing that by 100. So it's just to calculate the percentage dehydration. So this is something that you can remember, make a flashcard if you're feeling fancy, but it's not something that is especially high yield as a calculation to remember. So if it's like the day before the PSA and you can't remember it, don't have a breakdown. It's there just so that you're aware. So yeah, I hope that makes sense. So we'll go through the first question. Actually, no, we won't. We'll do the first question now. If you can all just make sure, if you're wanting to keep up the pace, if we can just make sure that we're reacting to the message in the chat, so then I know if people have done. So yeah, and then we'll move on to the next question once you've done that. So you've got patient who's 6 years old, they've been admitted with meningitis and they're septic. They weigh 23 kilograms. The observations are there. Please prescribe appropriate fluids for this patient. Okay, so I can see you're all responded to that message quite quickly. So hopefully you're all done with the question. So essentially, calculation here will be 10 times 23, because hopefully you can all identify from the patient's observation that they're extremely hemodynamically unstable, and so prescribing maintenance fluid wouldn't be appropriate in this situation. They need resuscitation fluids and they need them quickly. So that'd be 10 times 23, which gives you 230, so it would be 230 mils of normal saline, 0.9% in 10 minutes. And so hopefully you all got that. Move on to question 2. So patient B is a 12-year-old that's been admitted to hospital with appendicitis. They're due to have an appendectomy in the morning and have been made nil by mouth. You've asked to prescribe maintenance fluid for this patient. They are hemodynamically stable and have no losses that require replacement. They weigh 36 kilograms. Please prescribe appropriate maintenance fluid for this patient. So again, just react to the message when you're happy to move on. I think the message has just gone in the chat, so you can all react to it whenever you're ready. Okay, so I can see you're all reacting. So we'll go through the answer. So essentially, this is a question where we're doing maintenance fluid, we've not got any losses, and so we're going to use our Holiday Seagull formula. Because of the patient's weight of 36 kilograms, the equation should be as written there. So 100 times 10, 50 times 10, and 20 times 16. That gives you 1,820 mils in a 24-hour period. I personally just find it a lot easier for my own working out to figure out how many mils per hour that is. And that's something that I personally do in clinical practice. So I would do that number divided by 24, and that gives us roughly 75 mils per hour. I then would divide 1,000 by 75. That just tells me how many hours to prescribe the bag of fluids over, and that gives you 13 hours for one bag. In terms of what fluids you prescribed, essentially in this patient, basically anything would be appropriate, to be honest. We know that as people, we require water, we require electrolytes, and we require glucose over a 24-hour period. And so if you prescribed either normal saline, Hartmann's even, glucose, or you prescribed one of the kind of funky bags, which is like saline with glucose or something along those lines, any of that would be fine. Just making sure that it's a fluid that is safe to prescribe for a child. So for example, not doing like the 0.18 saline, or not prescribing something with a load of potassium when we've not mentioned any potassium deficit for this patient. But yeah. Okay, so question 3. So patient C is a 14-year-old who's been admitted with an ulcerative colitis flare. They are estimated to be approximately 7% dehydrated. They weigh 55 kilograms. Please prescribe an appropriate bag of fluids for this patient. I probably should have mentioned with the last question, but when we're talking about prescribing fluids in these questions, it's just what your initial bag of fluids would be. So don't worry about kind of thinking about what you would prescribe over a 24-hour period. Just the nurses have come to you, they've said, do you need fluids? What are you going to prescribe first? So yeah. And yeah, to Netra in the chat. So 0.9% saline alone, that's absolutely fine. Yeah. Just to come back actually to Net's comment about if normal saline is alone okay, it is okay. If, for example, though, they said somewhere in the question that they'd previously had a bag of normal saline, in that case, I would maybe go for dextrose over that, or if they'd already had dextrose, I would go for saline over the dextrose and things like that, just about making sure that they're getting like a variety of different fluids to meet all of their needs in the 24-hour period. Oh, with the fluid deficit calculation, I've just seen your message, Humna. I would do that as the patient's current weight that they put in the question. Yeah, I haven't seen it I haven't seen it all actually where they've given two different weights for the patient. So yeah. Yeah. So yeah. As you can see in this question, if, for example, if they did give you two weights, I would generally probably go for the well weight actually. But yeah. But I'm not 100% sure on that. But yeah, I've not seen it where they've given multiple weights previously. Okay, so are people happy if we move on to the answer for this one? If you react, if you're happy. Sure, people have. Okay. So hopefully for this one, your first step for this question would be to work out what your fluid deficit is for this patient. So that'd be 7 times 55 times 10, which gives you actually quite a significant amount of fluid. I was quite surprised when I did the question. So it's 3,850 mils, and then your maintenance you would calculate using that calculation. And so this patient's maintenance would be 2,200. Yeah, I've said that right, mils, which gives you a total amount of fluid required of 6,050 mils over a 24-hour period, which is a really, really significant amount of fluid that this patient needs actually. But that also does just go to show that even though 7% dehydrated sounds like quite a small amount, it's actually a huge amount of dehydration that patient's got. When I was kind of looking up about the kind of percentage dehydrations and stuff, just for context, dehydration of kind of 10% or above, which is most commonly in DKA, that's actually classed as an emergency. So just to show how significant such a small percentage actually is clinically. So yeah, so for this amount of fluid, you're looking at roughly 250 mils per hour. And so essentially what I would prescribe would be any of those fluids, or I put NaCl 0.0%, there, just ignore that, I meant to put 0.9%, any of those fluids over 4 hours. And if in clinical practice I was actually prescribing this for a patient, I would prescribe maybe a bag of saline and a bag of 5% glucose, or I would make sure they'd have at least kind of 1 or 2 bags of the glucose at some point over the day, just to make sure that all of those needs are met. Or if you work in my hospital, our general fluids prescribed has glucose in it anyway, so that's covered. But yeah, we've got 2 more of these questions because I am aware that fluid prescribing was something that was quite highly requested for us to go over in the session, because I think fluid prescribing in general is a bit confusing, but especially in paediatrics. If anyone wants to skip over this, that's fine, but we have just got 2 more questions. So we'll keep going with them unless anyone's got any huge objections. So patient D is a 14-year-old who's been admitted with gastroenteritis. While in ED, their observations have begun to deteriorate. They weigh 48 kilograms. Their observations are there. Please prescribe appropriate fluids for this patient. And just for context, observations for a 14-year-old, I know they can be different for children. Your ranges are essentially the same for a 14-year-old, so as what they would be for an adult. And yeah, naturally. So I've just seen. So why do you prescribe it as 1,000 ml? Is that just because the bag it comes in? So yeah, essentially. So most fluids come in either 250 ml, 500 ml, or 1,000. If we're prescribing quite a high like volume, obviously, you know, in pediatrics, in resuscitation and things like that, especially with smaller children, you do have random quantities of fluid. So like 230 mils, or like we had in that previous question, and things like that. Yeah, things. But generally, if you're going to be prescribing fluids, unless it's for a very, very elderly patient where they're very frail, so you're worried about fluid overload, or a very small child, and again, you'd be worried about fluid overload. For people that need kind of at least, I'd say, kind of 1,000 to 1,500 mils over a 1 day period, I'd always just prescribe a 1,000 ml bag, just because that's what it comes in. If you want to prescribe, for example, 2,000 mils of fluid, what you would do in that case is you'd actually would have to prescribe them as separate bags. So on your drug card or on whatever online system it would be, at the hospital you worked at, it would be like separate prescriptions, if that makes sense. And yeah, sorry. So I can see someone's actually replied to pull your question in the chat. But yeah, so although I know percentages we quite often think is like not is like decimal equivalents, it's the actual number of the percentage, not the like decimal equivalent of the percentage. So it would be 7 times 55 times 10. Because yeah, and also if you think about it, I guess 38 mils would be quite a small fluid deficit. And yes, Chloe, Hartman's is absolutely fine to give as maintenance for children. The only kind of time I would be maybe a bit more worried about that is if you're worried about like electrolyte abnormalities, if they have like hyperkalemia, but that'd be the same as in adults because we know Hartman's has potassium in it. But yeah, so same concerns with Hartman's in children as adults. Okay, is everyone happy if we move on to the answer for this question? I appreciate there's been quite a lot of comments in the chat, so maybe the message has got a bit lost. So we'll go on. And yeah, if anyone has any questions about the answer, just let me know. But hopefully all of you can identify that although the observation's not quite as dramatic as the previous one, this patient is still hemodynamically unstable. We know that because our blood pressure is significantly lower than our heart rate. And so we do resuscitation fluids. This patient would be 10 times 48, which gives us 480. And so we do 480 mils of normal saline in 10 minutes. And yeah, just to know that obviously, so this is a 14-year-old and they're just under that 50 kilogram weight category. If, say, for example, this patient weighed 58 kilograms, I would just personally cap it at the 500 for resuscitation fluids, because that's what we give in adults, and it wouldn't make sense to prescribe more fluids for a child than what you would for an adult. So it's just when you're getting into teenagers, just to keep those things in mind. And our last question in this section, so is patient E is a 9-year-old who's been admitted with diabetic ketoacidosis. They weigh 23 kilograms and are approximately 8% dehydrated. Please prescribe appropriate fluids for this patient. I probably should have specified we want you to prescribe replacement fluids for this patient, not resuscitation, which is why we've not included the observations here. So if we can all just let us know when you're all happy to continue. And we're nearly at the end of the session now. Okay, so I can see a fair few people have reacted. So we'll go through this question. So patient E is a 9-year-old who's been admitted with DKA. Oh, I've already read out the question. Why am I repeating it? So first step for this question, for me personally anyway, I would just work out the deficit to begin with. So that's 8 times 23 times 10, which is 1,840 mils. Then I have to work out your maintenance fluids for this patient, which will give you 1,560 mils. And so your total fluid required over a 24-hour period for this patient would be 3,400 mils, or 140 mils per hour, however kind of is easier for your brain to digest it. I personally then would do 1,000 divided by 140, and that gives me one bag over 7 hours. And so that's what I would prescribe. So I would do saline over 7 hours. Can anybody think why I've said saline rather than dextrose for this patient specifically? Yeah, exactly. So yeah, because they've got DKA. So as much as it can be really easy to just think, oh yeah, like dextrose, whatever, or yeah, I'll just give Hartman's or whatever, or whatever it might be, just making sure that your fluid's appropriate, not just for the amount of fluid you're prescribing or the scenario which you're prescribing it, so maintenance fluids or resus fluids, but also that it's appropriate for the clinical scenario. For example, on the flip of this, if I had a patient and they had hypernatremia, I would not prescribe normal saline for them. I would prescribe dextrose instead. And so it's important to essentially keep in mind the kind of information in the question, which, as much as it might sound quite a simple thing to keep in mind when I'm saying it now, when you're very stressed in the exam and things like that, it can be easy to forget these things. So it's just to keep in the back of your mind. And yeah, so exactly. So why I do 1,000, this is genuinely how I just prescribe fluids on the ward and just works for me. But because I know generally I'm going to prescribe one full bag of fluids because it's just easier, that's how it comes, and for the reasons we discussed before. It essentially, if I know that they need 140 mils per hour, I can work out roughly how many hours they need that bag of fluids over. So 1,000 divided by 140, that gives kind of roughly about 7 hours. So that's why I would do that, and that is generally just how I prescribe all of my fluids, not just in like these scenarios, but it's useful for clinically. Quite often the consultant might say to you, like, prescribe a 1 litre bag of saline, but they won't say how long they want it over, and so I would work out how long to prescribe it over based off clinical scenario, but also what the patient's weight is as well, and things like that. So yeah. Okay, so that's us done with off-fluid prescribing. I appreciate. Yeah, so yeah, Netra, exactly. So essentially, if I prescribed 1,000 mils over 7 hours, essentially when that 7 mil bag had finished, I then would go back, prescribe another bag, or like hand over to whoever was taking over from me to prescribe another bag once that bag's finished, and things like that. And so over a 24-hour period, the patient would end up having roughly 3,400 mils. So they're getting enough fluid, but essentially you're just prescribing one bag at a time. Because, for example, one, you can't prescribe 3,000 mils all at once, but also, say, for example, you prescribed 3,000 mils all at once and then they had an underlying heart condition you didn't know about, and then they go into like fluid overload. It's just safer to do one bag at a time and things like that. So yeah. Okay, so last little sections. This is just to run through some common pediatric prescriptions that come up, just to keep in the back of your mind. Also, yeah, sorry, Paul. So now your question, but would the nurse set the machine to dispense 1,000 ml over 7 hours? I'm actually not sure the answer to that question. I don't know that well how the machines work. I think off the top of my head, they do 140 ml, and I don't know actually. I should probably find that out. I genuinely don't know. In terms of when I prescribe it, at least at my trust, all I do is I prescribe the like like mil amount and then how many hours I want it, whether the nurses then have to work out how many mils an hour that means from there, I'm not too sure. Okay, yeah, so has answered that. But yeah, good question, a good thought. So yeah, common pediatric prescriptions. So these are just things that commonly come up that are different in children than they are in adults. So it's just to keep in the back of your mind, because I think there's certain drugs that we maybe just naturally tend to just hear the drug and think, oh, I'll prescribe this much straight away, because it's a commonly like emergency scenario thing quite often. So I'm thinking things like adrenaline, like aspirin, things like that. You know, you hear aspirin, you think 300 milligrams, like that kind of thing, but it is different in peds, not specifically aspirin, but these ones that come up a little bit more. So the first thing just to keep in mind is about your adrenaline. So it is different for adrenaline versus an adult versus like a neonate. Neonates, I'm going to be honest, I really don't think that's something that you need to worry about too much. I don't think I've ever had a question about neonates come up, but essentially either way, it's kind of your 10 micrograms per kilogram every 3 to 5 minutes. And that's your 1 in 10,000. So these again are just little things that you can find on the BNF, and so don't worry if you don't remember them, or you get mixed up when you're doing your flashcards about them between these and the adult doses. It's fine, you can find them on the BNF if you need to. But this is a common difference between pediatrics and adults, is your adrenaline doses. Both for, you've got your CPR dosage, but you've also got your anaphylaxis dosage. And your anaphylaxis dosage is the one that I think comes to mind more often about something that's more likely to come up. But essentially with your anaphylaxis dosage, it essentially depends on your age, how many micrograms that you prescribe. So our adult dose is the same as our kind of child from 12 to 17 years, so it's 500 micrograms. But for a younger child than 12 years old, you just have a slightly reduced dose. So 6 to 11 is 300. 6 months to 5 years is 150. I think it'd be very unlikely that you'd be giving child up to 6 months, but to be honest, because the child up to 6 months, it says 100 to 150 anyway, I personally would remember that as if they're 6 to 11, it's 300 micrograms. If they're younger than 6, it's 150. If they're older than 12, then it's adult dosing anyway. So yeah. We then also just have a couple of common presentations. So one of the most common ones when it comes to pediatrics is asthma. And I just wanted to bring this to your attention just because the doses are ever so slightly different in children than they are in adults, but this is a common adult presentation as well. So with your prednisolone, you've got slightly reduced dose in children age 1 month to 11 years. So that's based off weight, which we did actually cover earlier. And with our salbutamol dose, for children aged 5 to 17, it's the exact same as the adult dose anyway, but for 1 to 4-year-old, it's just an ever so slightly reduced dose. These aren't things I necessarily think you need to remember off the top of your head. It's just to make you aware that in common presentations in adults, it is different in children what your dosage is, even if the treatment's the exact same. So yes, and another common one that just comes up a lot is croup. So for croup, you actually can prescribe prednisolone for it, but I think dexamethasone is more common. They use it, at least kind of when I've been doing these questions, I've normally prescribed the dexamethasone, and that's just 150 micrograms per kilogram. That's generally given as just a one-off stat dose, but every now and then in very severe cases, they might need further dexamethasone. And yeah, but essentially all of those you can actually find quite easy on the BNF and your BNF treatment summaries. I know they're not quite as helpful all the time as the ones on CKS, but they're still there and have some really good information. So don't discount your treatment summaries in those common presentations and things. So yeah, so I hope that was useful. If anybody's got any questions, I can see Sarah, you've messaged about the link to the second recording. I can raise that with the MedEd team and make sure that it's been sent out to everybody who went to the second session or like filled in the teaching form and things like that. If anyone else has any questions about pediatric prescribing, please do let me know. Perfect, Netra. Thank you. Oh, I've just remembered we need to do the feedback form. Sorry. Zainab, if we can just make sure that we've got the feedback form for people.